Today, we have the distinct pleasure, and I'm really not kidding about this, this is an absolute pleasure for me, to talk with Dr. Roy Taylor. He is a physician, a diabetologist, and an author. Is currently the director of the Newcastle Magnetic Resonance Center. And that's in England, by the way, so he is zooming in from England today. Very, very kind of you, Roy. Dr. Taylor has worked on identifying the cause of type 2 diabetes and furthering retinal screening for diabetic eye disease in the United Kingdom. He has been conducting research on type 2 diabetes since 1978, before I was born. It's crazy. In 2011, Taylor showed that type 2 diabetes was a simple, reversible condition that we've learned about throughout this conference. And it's reversible due to excess fat and liver in the pancreas. Now, on a personal note, Dr. Taylor, I have relied very heavily on his research. He was one of the forefathers of this when diagnosing the LEADR trial. That's my trial, the Lifestyle Empowerment Approach to Diabetes Reversal. And he is one of the most congenial and wonderful, enjoyable people to talk with. So I'm really excited to hear from him, and I hope you guys enjoy the same pleasure that I have talking with him as well. So, Dr. Taylor, hello.
Hello, Scott. Thank you very much for that kind introduction. So, are we all set to roll?
We are set to roll, yes.
Excellent. Well, good morning, everybody. It's a pleasure to be talking to you, even though, sadly, I can't be with you in person. But let's just start off on this lonely hillside just outside Newcastle upon Tyne, upon which stands a remarkable statue. It's called the Angel of the North, and it's a sculpture which represents the industrial past of the area, but in a unique form. And this is a dramatic thing. It's 20 meters high. These are real people, by the way. And it has a wingspan of 60 meters. It's enormous. But sometimes when you look at it, it appears to be a man. Sometimes it appears to be a woman. But just look at this. If you consider the waist to hip ratio, there it stands, an enormous statue to metabolic health, trying to lead the way for all the people of Newcastle. Sadly, it's still got a lot of work to do, but nonetheless, quite a thing. But the job of an angel is really to look down on people and to understand their motivations, their foibles. And in the same way, I'd like to look down on type 2 diabetes and try and convey our present understanding of this simple condition, a homogeneous disease of etiology that happens in heterogeneous people. So simple. So where should we start? Well, firstly, I'm afraid my slides are not changing for some reason. Can I just try and battle with this?
Oh, he said to click the arrow on the bottom. Try that.
Click the arrow on the bottom.
Yeah, right there.
Oh, well, there we go.
Perfect.
I'll click on that arrow, hence 2-4. So my disclosures, not relevant to this lecture. I'd like to start from a very basic point of physiology, because understanding physiology is really the starting point. We've got to build solidly up from the basis. Now, all of us stayed alive overnight. That's why we're on this call. But the only reason we could stay alive is that our brain was able to be powered with a glucose for energy, an enormous amount of glucose for energy. Yet, blood glucose stayed even overnight for most of us. And that is only because it's continually added to the blood from the liver. Now, this is an absolutely essential relationship to understand. So here we have this relationship of the liver to glucose in the blood, maintaining a constant level. But of course, what maintains it is insulin because it operates a very nice tap here. So it controls this constant flood. How much glucose were you producing every hour last night? Well, if you were an average person with insulin sensitive tissues, you'd be producing about 10 grams per hour overnight. 10 grams every hour. It's a huge flood. We tend to forget what an enormous flux of glucose is going on that we never recognize because we're only measuring a level. It's like looking at a rapidly flowing river and saying, well, it can't be very important because it's not very deep. It's the speed of the water that is important. In 90 minutes, you would have changed every single molecule of glucose in your blood and extracellular fluid. So we're dealing with a constant flux, and grasping that is really one of the first points because it points up how important it is for this tap to be working properly.
Clean, moisturized, sunscreen.
If we seem to have a cross wire somewhere. If we have a fault in the sensitivity of the liver, hello?
Hello?
Yes?
Yeah, I hear you now.
I was getting some interference from a different lecture there. Was I coming through okay?
Yes, you're coming through okay now.
Excellent. But was I coming through okay before then?
Yes, you may move forward. Thank you.
Excellent. Okay. So here we have the vital role of insulin, but it can be gummed up. This tap may be jammed on. It drips if there is insulin resistance. Now, around about the year 2000, several groups, including our own, discovered that it was the fat in the liver that caused the liver insulin resistance. It's quite different from muscle insulin resistance. Liver insulin resistance was due to a metabolic reason. And the excess liver fat caused the insulin resistance. But of course, if there's insulin resistance, then there will be excess production of glucose and failure to stop the glucose pouring out of the liver. So in type 2 diabetes, instead of 10 grams, the average production each hour is 15 grams. Not a small difference, a huge difference. So here you see 15 grams of glucose in each glass. I measured them out myself and put them in these glasses, 6 of them, just to show you the amount of glucose that poured into the blood from the liver in your patients with type 2 diabetes. People may have asked you, why is my blood sugar sometimes higher in the morning than when I go to bed, doctor? I don't understand. Well, it's quite simple. The fasting level is due to the liver insulin resistance and trying to cope with this terrible problem. So a really big problem to deal with. So what do we do about it? Well, we put all this together in the form of a hypothesis, the twin cycle hypothesis, set about testing it, but I want to show you just one result, because if what we thought was true, we might see not much change in the liver fat content and no change in the plasma glucose. So let me take you through this. Here we have an MRI scan, but no ordinary MR scan, one that is conducted by the physicists in our research center. Every pixel in this image is color-coded for the amount of fat at that point in space. And the key is over here. 100% fat is red, no fat is black. So here we have the subcutaneous tissue over the abdomen, the front of the abdomen, that of course is red, it's fat. Going round to the back. Inside the aorta, of course it's black because blood is largely water. But this is the upper abdomen. And this organ is, of course, the liver. Just look at its color about here. And in fact, numerically, it was possible to determine that this individual who had unremarkable type 2 diabetes, not recognized to have any liver problem, had a liver that looked like this. Now, this is high for type 2 diabetes, but I show you this example to point out that it's an asymptomatic condition. And in our study to test the hypothesis, we wanted people to lose weight, 15 kilograms of weight loss. And so they did, and this is what they looked like afterwards. Just look at that liver. It's down here, and strictly, it was 2% fat. And since this, we've observed this in repeated studies. The fat can be removed from the liver insulin resistance disappears. Dramatic. Now, I said the one test would be the liver fat shifting, but the other test would be the fasting blood glucose. So what happened there? Sorry, I'll just lead into this by pointing out that there are two features to the liver's supply of energy. One is supplying the whole body with glucose that we've just discussed, but the second is a parallel production by the liver to look after the whole energy, because metabolism, energy metabolism, it's a simple business. We only have two main fuels in the body, glucose and fat. Nothing else. Sure, you might say there's ketones, but yes, that's a workaround for a specific circumstance. So here we have the liver controlling everything, and if there's excess fat in the liver, we might expect excess fat put into the blood. Let's jump sideways. How about your test results on your people with type 2 diabetes? You will know that plasma triglyceride is 50% increased on average compared to an equivalent person without diabetes. And that 50% increase is actually determined by the liver output of this lipoprotein. I'd just say that lipoprotein metabolism is dealt with in a shockingly obscure way in the textbooks, but it's dead simple. There's only one lipoprotein. It's this one. All the others that biochemists love to document are merely when this has shed part of its payload and we're looking at a slightly smaller particle. So there's no mystery here. This is the triglyceride. Cholesterol outside, triglyceride inside. And the study results. Here we've moved on to the plasma glucose. So on day one, we stopped all hypoglycemic agents. So this group of people with very ordinary diabetes, but just in the first 4 years. And we started the 800 kilocalorie diet. Look at the effect size, down to normal. Now, this bears a comment because any drug study goes nowhere near this. If we were to use insulin, you cannot mimic this because you can't bring about this fall so rapidly without wildly overshooting and causing problems. But here we have, within 7 days, a return to normal. But we were conducting this study in the Magnetic Resonance Center. So we were able to look inside the body, to look at the fat inside the liver, the fat inside the pancreas, and of course we can do metabolic tests as well. And because of all that, we were able confidently to say that at 7 days, the liver fat had fallen by 30%. The plasma triglyceride had gone down by 1/3. In other words, back to normal. In millimole per liter, it had gone from 1.5 down to 1.0. So we'd seen normalization of a parameter, triglyceride in blood, which usually stays abnormal, despite our best efforts to treat type 2 diabetes. But also at 7 days, absolutely astonishingly, we were able to document the liver insulin sensitivity returning to normal. It is so fast, it's a metabolic effect of the liver fat. Bring down the liver fat, specifically removing the toxic lipid intermediates, then the insulin resistance goes away. And let me emphasize that muscle is totally different. The muscle insulin resistance did not change. That is a far more fixed affair. And despite all the hype about improving muscle insulin sensitivity, in reality, it changes relatively little for an individual. In total contrast to liver, which we can now dissect off and say, this is a treatable aspect. Because triglyceride impinges upon the islets and can decrease function in people with islets that are sensitive to triglyceride, we had predicted that we might see an improvement in beta cell function. And to my astonishment, we did. We showed a slow return of first phase insulin response. It was pretty good by 8 weeks, but our subsequent study shows that it's not maximal until 1 year after the rapid weight loss phase. Now, I've presented to you data and items of interest, but let me wind backwards and show you the original hypothesis. Here we've gone back to, it was thought about in 2006, but it was published in 2008. And I'd like to talk you through this diagram. We've got a group of people who are just eating perhaps an extra mouthful more than they should do or than they require over a long period of time. Especially those people with pre-existing muscle insulin resistance. And don't forget that pre-existing muscle insulin resistance is the first detectable abnormality in people who are likely to get type 2 diabetes. How do these people handle their meals? Well, I can tell you that those of you who are listening who have normal insulin sensitivity in muscle will store 1/3 of your meal carbohydrate in muscle by 5 hours after eating. We've been able to demonstrate that, again, using magnetic resonance spectroscopy. But in people who have insulin-resistant muscles or relative insulin resistance, they store almost no carbohydrate in muscle. What happens to the rest? De novo lipogenesis. It is turned from glucose into fat because that's the only metabolic pathway left in the body that the body can handle this surge of unpleasant, osmotically active poison, the glucose. So here we have liver fat slowly stacking up, helped by this factor. And you can see that this will trigger a sequence of events. I've already described the insulin resistance and the lack of insulin control on putting out glucose, which is going to cause insulin secretion to rise. Paradoxically, that actually stimulates this turning of glucose into fat. But over time, plasma glucose will begin to creep up. Now, one of the first proofs, as it were, of this hypothesis was that in 2011, the Whitehall 2 study was published, and we were able to follow a group of civil servants in London who were able to be tracked over the 12 years before they developed type 2 diabetes. Plasma glucose, fasting plasma glucose, rises slowly over this period of time. So that's the time base we're dealing with this. But it doesn't stop there, because this liver fat is going to be exported, normally to subcutaneous stores. But if they are relatively replete, we'll end up with too much triglyceride in the blood. Exposure of beta cells to too much triglyceride will, in susceptible people, decrease the acute insulin response to food. That'll leave plasma glucose up for longer. That will cause further insulin secretion. That will cause further de novo lipogenesis, process which only happens in the liver in humans and is responsible for this horrible increase. We've known for a little while that before the diagnosis of type 2 diabetes, the enzymes, the liver enzyme tests, ALT and gamma GT, are both raised. Why is this? It's because the liver is giving out a long silent scream in this phase of moving inexorably towards diabetes. It's a horrible process, but it can be interrupted. And in fact, change it into reverse, but we're talking about the development at the moment. So these cycles grind on, as you can appreciate, mutually interacting until a certain point when quite rapidly plasma glucose rises. And that is indeed what the Whitehall study was able to show. So though we have the hypothesis, and I've already presented to you the testing of the hypothesis and the fact that our findings were entirely consistent with that idea. But this is controversial still in some countries. In the UK, it's largely game, set, and match. But it's argued against vehemently by experts who want to keep this disease complicated. And one of their main arguments is that can't explain type 2 diabetes. It can't be a disease of homogeneous etiology. Because, look, there are some thin people who get type 2 diabetes, so it can't be the fat. Well, it can be the fat. And together with Rory Holman, who is one of the brains behind the United Kingdom prospective diabetes study, we wrote up a second hypothesis in 2015, the personal fat threshold hypothesis, which goes like this. We all have a finite capacity for storing fat under the skin, and that's metabolically safe. But if we can no longer put it in that compartment that's safe, it spills over into the middle and causes mischief. We were able to use some of the UK PDS data, previously unpublished, to back up our claims. But we now have a test of this. But let me explain a little bit more how this works. Just imagine you're asked which of these men has type 2 diabetes. Well, you would say, well, Bill surely is the man with the diabetes. Fred, well, maybe. And Charles, no, not at all. But in fact, all of them have been referred to you with type 2 diabetes. They're all aged 45. But let me call your attention to how bad we humans are at conceptualizing time. Just think of these men in their life course. And this is how they were at the age of 25. Charles, cross-country runner, really very fit, and just whippet breed, we call it in the UK. And here we have Fred, who played football, soccer, and really quite fit. And here we have Bill, the rugby player, who needed his mass to play his game. All of them have put on a similar percentage weight entering into middle life, settling down, no longer frantically going out socializing in the evenings, settling down with family, children, busy at work. All these things happen in our current food environment. This is the result. So that's a concept. But of course, it's a testable concept. So once again, we set out to destroy our hypothesis. Because if we take a group of people who look like this, get them to lose weight, and their type 2 diabetes doesn't go away, we're wrong. Fantastic. We will achieve clarity. This is exactly what we've done. And in the Retune study, we were able to show that 70% of these people who look like Charles achieved remission with weight loss within the normal range. But we could show that the fat inside the liver was excessive for them and also fell dramatically with that weight loss, with the return to metabolic normality following. So the Retune study is yet unpublished, but when it comes out, I hope it will turn heads and just make the experts rethink their opposition to seeing the simplicity of why type 2 diabetes becomes rare in conditions of food shortage, beautifully documented after the Second World War, indeed in 1870. During the Siege of Paris, there's a convincing historical account of the same thing. The marvelous thing is the sugar disappeared from the urine of all my patients with diabetes, said Claude Boucheray. And even up to a modern disaster, when the Soviet Union imploded in 1990-91, Cuba was thrust into an economic disaster, and the beautifully documented healthcare system continued to document the fall off in rates of type 2 diabetes. Sadly, they turned a corner, and type 2 diabetes and obesity are back on the up. I can also present to you for the first time the results of the 5-year follow-up from the DIRECT study. Now, you may be aware that the DIRECT study was a randomized controlled trial to test whether it was simple in primary care, office-based practice, to get remission of type 2 diabetes using the process we had devised. And DIRECT showed indeed it was. But would it be maintained? That was a big question. So we followed up people beyond the 2-year RCT for a further 3 years, so a total of 5 years follow-up, just of the weight loss group. We were able to have basic data gathered on the others. And the follow-up didn't quite go according to plan because the staff in the doctor's offices changed over and they were no longer the enthusiastic, informed group who started the study, but nonetheless it happened. But just look, we actually were able to demonstrate maintained weight loss of 6.1 kilograms at 5 years. Now remember, this is a rapid weight loss process, which dietitians and nutritionists said, oh, that's unhealthy, with no evidence whatsoever. They said it will be immediately followed by a rebound to a higher weight, with no evidence whatsoever. But here we have the evidence that this is a profound effect upon ongoing body weight. Now, that weight loss is not sufficient to maintain a very high number of remissions, but the people staying in remission had an average weight loss of 9 kilograms at 5 years. And this group, of course, retained their remission. People retain their metabolic health. Type 2 diabetes is not irreversibly progressive, provided the weight loss is sufficient. But the dramatic point I'd like to emphasize is that counting the serious adverse events, which of course we were very keen to do so because we had to ask the question, is it dangerous to lose weight rapidly? No, 54% fewer. Excuse me. And I've taken the lid off this to look at what those are, and I think it will be of interest to this audience. What are you stopping your patients from developing? Well, yes, strokes were less, heart attacks and total cardiovascular disease about the same. But look at this. Less biliary disease, less metabolic decompensation, far less bacterial infections, and much less odds and ends that are really more than odds and ends to the individuals that get them. Green are those in the extension group we followed up for the full 5 years. But the big ticket number came in looking at the number of new cancers. This shows new cancers in DIRECT. They were all in the control group when compared to the extension group. That is astonishing. And this is not an unbelievably high number. It's what we would expect. And in fact, it just happens to be numerically identical to that observed in the Swedish obesity study, bariatric surgery study. 14.1 new cancers per 1,000 patient years in the control group. Now, the extension group were the people who are still in the study. But if we wind back to intention to treat, how about on day 1 of DIRECT, we had 149 people in the control group, 149 in the extension group. How many people got cancer? Well, 8 in the control group, 1 in the weight loss group. And remember, this person dropped out, probably put on weight. So here we have a benefit of this very obvious lifestyle intervention, you might say, but it's not lifestyle in general, it's weight loss. We can be very specific. There's no fuzzy thinking here. This is a targeted approach. And it's had its ramifications because the results of the RCT Direct led to NHS England evaluating this and saying, look, we want to find out if this could deliver healthcare on a big scale and save us money. So they set up a pilot scheme just in 10 different areas of the country. Now, I was part of the group designing the study, and I was very concerned by this. Because of the political slant of the government, it had to be provided by private healthcare companies without any particular basis. But hey, I devised the diet originally both to be effective, but also to be simple, to be able to be delivered by anyone. So maybe there's some sense in that. One of our other early studies I haven't referred to, the CounterBalance study, demonstrated that remission was commoner if the duration of the diabetes was rather less. And that's led to the 6-year mark for the NHS to say, right, we'll get more bang for our buck if we just look at this time. And the aim is for an initial weight loss of 15 kilograms with rapid weight loss and then maintenance. We have the data of weight loss at 1 year in the first few thousand people. 10.8 kilograms weight loss. So using a low-calorie liquid diet, about 800 kilocalories per day, managed properly with tight controls, this is achievable and can deliver at scale. And I'm absolutely delighted to tell you that 10 days ago, NHS England announced that this pilot scheme was no longer a pilot. Those 10 areas are going to be rolled out to the whole of England. So this is real, this is happening, this is moving forward. And I hope that will set an example for other healthcare systems to follow. Now, so far, I've talked just about the, if you like, the understanding of diabetes and our data on observing remission. But what was this diet? Well, here is the original diet with a packet of the low-calorie liquid diet, here made up in a pint of water, and a decent helping of non-starchy vegetables, because man is not metabolism alone. We need to keep the gut happy. That was the motivation for this. And we can identify the factors of this which lead to success. It's simple, it's practical, it can be done by people who travel for work, and indeed, people in the first study included that sort of lifestyle. But one critical factor we identified right at the start was if the spouse or partner does not want their beloved to lose weight, it will not happen. Now, this is a one-way truth. In other words, it's 100% chance it will not happen. And because of that, it's vital that it's discussed with spouse or partner in advance. And if they are on board, well, there's a good chance it could happen. The other feature is that the weight loss itself is duration limited. When this is reported in newspapers, it's described as a crash diet. A crash is something, I'm sure you'll agree, that's unpleasant and completely unplanned. This is completely planned with pleasant outcomes. So please, not a crash diet, but able to be planned in to a 2 or 3 month interval that suits the individual. Maybe away from wedding anniversaries and birthdays. This is a humanly possible thing. But there's one aspect of our work which deserves to be emphasized and put into perspective. Please, no additional exercise during the weight loss phase. That might cause a sharp intake of breath. But hey, let's be realistic about this. How many of you have friends who've joined a gym, worked away for ages and said, it's no good, I'm just not losing weight? The biggest kept secret in the whole of the obesity field is that the onset of exercise programs is associated with compensatory eating in people who are already overweight. And that renders the exercise counterproductive during the rapid weight loss phase. After the weight loss phase, certainly we encourage movement, because Renee Wing's very nice studies on long-term maintenance of weight loss show clearly that those people who indulge in the most physical activity day to day do the best. So let's get the message clear. Don't try and mix up exercise and weight loss by diet. You need the diet to achieve the weight loss and the exercise to help keep the weight loss from returning. I was astonished when I found that my patients liked the low-calorie liquid diet. I thought it would be a bit of a penance to bear. I found it very easy, said this man. Well, I think he actually means simple rather than easy, because there are challenges. There's no point in saying otherwise. I started to see weight loss fairly quickly, and that's encouragement in itself. People describe suddenly being able to run upstairs, suddenly being able to leap out of a chair, chase the grandchildren. It's marvelous. The average weight loss in the first week on an 800 kilocalorie per day diet is 3.5 kilograms. In other words, about 8 pounds. Half of that is water, of course, the early weight loss. Half of it is fat. After that first week, it's virtually all fat loss and about 4 pounds a week. So the reinforcement of the early weight loss is quite critical. And again, this man reflects the same, I feel great. Factors for success, determination, and family support. People are not islands. No man or woman is an island. And we need to involve the family, the friends, the workmates, with people who want to do this successfully, because the food environment, the approach to food and how it's offered to people needs to be taken into account in this. But the doctor also needs to take an appropriate approach to this. So the simple explanation. Person with type 2 diabetes, you've built up more fat inside your organs than you can cope with. It's not to do with obesity. You lose 15 kilograms, you'll still be obese, possibly. It is not obesity. This is something completely different. It's just that you have exceeded your personal fat threshold. This is a concept that my patients grab onto most readily out of any concept I try and put over. Then the confidence in explanation. This is not fuzzy thinking of hoping and, yeah, it's a diet we might try. No, there's a 2/3 chance of getting complete remission if you lose more than 10 kilograms, 22 pounds in weight. But even if you don't get complete remission, you're going to normalize your risk of heart attack. Now, I know that because of the 10-year risk measurements of heart attack. We need to gather the further data to be able to get complete data on that. But for the moment, we can have confidence in what we can say. Also, it's not as difficult as you might imagine. After the first 2 days, you're not hungry. There's no fatigue. Fatigue is nothing to do with calorie shortage. That's just how we're set up. Presumably, we were still able to chase the hairy mammoth to get food when we hadn't been successful for several weeks. And it works. You'll feel younger and fitter. No serious side effects, unlike any medicine. You name it. The new weight loss drugs, for instance, then side effects, but this, no, none. Yes, possible headache, some people, it's unusual. Some people can exhibit temporary hair thinning, just like in pregnancy, just like any severe illness will cause the same. It's called a telogen effluvium. The hair growth returns afterwards, but no serious side effects. And as I've just shown you, really very beneficial effects. All the how to do it information has been online since 2011. And also the book, Life Without Diabetes, published in the States, gives a very full account. Now, this is not a commercial break for the book. All profits from the book go directly to Diabetes UK, which funded this work. And that was a bold step, because a lot of my colleagues thought it was a wacky idea at the start. And as mentioned, some experts still do. So I hope I've been able to get you to look at type 2 diabetes from a different angle, the physiological angle, to understand what's going on inside the body. So if we were to ask the angel what the summary of this talk was, well, I hope the angel would say type 2 diabetes is a state of excess fat inside liver and pancreas, excess being above a personal fat threshold. And weight loss by any means is the primary goal of therapy. Thank you.
Dr. Taylor, thank you so much. I want to invite people to ask questions. First, I'm going to mention an opportunity that we all have. I mentioned before I'm running a study starting in August and September this year that has borrowed heavily from Dr. Taylor's expertise in his publications. We are starting a trial called the Lifestyle Empowerment Approach to Diabetes Reversal. This is the LEADR trial. Right here in downtown Ogden, we're going to be recruiting 84 patients. Hopefully, some of your patients would be kindly referred. We can contact you later about those. And what we are trying to do is see if we can come up with a reliable and effective and durable lifestyle approach to reversing type 2 diabetes. This will be the first controlled trial in history that we're known of, that we know of, that will be able to show that we can reliably reverse this through lifestyle modifications alone. We are specifically not going after directly weight loss. We want to see if we can do that with a whole food, plant predominant diet, and we're incorporating other lifestyle modifications into the curriculum as well. Though weight loss we do expect is going to be a natural side effect of this. So if you are interested, we're running a pilot trial for reimbursement, and if anyone's interested, please come contact me after this, because we can definitely get you onboarded with that. And we'll be hopefully starting the real trial in August and September. So without any further ado, I want to allow you to come up to the microphones and ask Dr. Taylor any question. He is the grandfather of diabetes research in our age. Go for it.
I asked Dr. Taylor, I enjoyed your presentation, why the design model with the very rapid weight loss, which for some people may be unsustainable. Why not do this over a longer period of time with slower weight loss?
Because I'd been sitting in my clinic for decades listening to people describing their experience with trying to lose weight. I was faced at that time with the need to test the twin-cycle hypothesis. So I wanted a surefire way of getting weight loss. And I knew from some old studies that once people were on the low-calorie diet, they didn't have hunger. I could also see that one of the other major features that have been described to me, this terrible day-to-day cumulative burden of what to eat, how much to eat, can I eat that, is that half a cup full? That would not happen if people were just having a liquid formula-based diet with non-starchy vegetables. So it was knowledge that we could use this in a way to test the hypothesis that I expected to be successful. I calculated we would need 15 kilograms of weight loss to test the hypothesis. That was a very lucky back of the envelope calculation. in that study, we got 15.3 kilograms. Now, that explains why we started using this. Why have we continued using it? Well, as reflected by some of those quotes I showed you with the independent psychologist's review of what people think about it, people actually like this. Now, if it's approached by saying, well, we've got this idea about treating your diabetes using 800 calories a day, it's not going to fly. This is a matter of choice. We can either manage your diabetes with pills and we'll deal with complications as they arise, the eyes, the kidneys, stroke, heart attack risk, etc. Or you've got a chance of returning to health. It's not easy, but this is how we could do it. So it's not something that people find difficult. And the reason why NHS England is able to roll out and get these large numbers is that what doctors think about this diet in advance is simply not true. And once the doctors had experience of one person going through it, they become ambassadors for this diet. So that's a word about where the idea came from and why we still use this as the preferable way to achieve the degree of weight loss we need for people with diabetes.
Thank you, Dr. Taylor, for your presentation. I'm a retired endocrinologist, so I found your report very interesting. However, I am concerned about the long-term remission of diabetes. I mean, that is the ultimate goal, and you have followed some of these patients out for 5 years. Are you continuing to follow them, 10 years, 20 years?
We should be able to have data on them because of being able to follow them through the NHS data linkage. The NHS remission program will be able to do this in a highly efficient way, so we'll gather data on large numbers. It's been one of my frustrations that I've been unable to track people because that requires quite a lot of energy and time merely to do that. But I know that those people who keep their weight down do not go back into type 2 diabetes. My longest duration patient actually insisted on seeing me and demanded a way out of type 2 diabetes because this was a doctor patient. And this person demanded this in December 2004 when the twin cycles were running around my head and I got as far as figuring that we should be able to resume normal fasting plasma glucose. So I advised, that person lost their weight, they went back to the BMI they had when they were 21, and I can tell you that they're still at that BMI today, they're still off metformin, and they have no diabetes. And we've got a range of people who we've followed up. I've tried to write up these cases, but allocating time is difficult. I'm certain that when we remove the fat from the beta cell, it will return to as normal as it can, and then it does not deteriorate. And we need to have complete confidence that that is the case. The data is hot on our heels to actually prove the point.
Thank you.
This is a follow-up on that first question. So the prevailing wisdom has been 1 to 2 pounds of weight loss per week is considered safe. And beyond that, we are having some muscle loss. So if you'll speak to that further, because my concern is
Yes.
if you're losing muscle, you're losing the more active metabolism of muscle versus fat within that, and then long-term implications. Is that so helpful by decreasing that resting metabolic rate for ongoing weight loss?
Yeah. Now, we have measured the change in muscle mass. It is very small. But let me suggest an experiment. I would like you to walk around with 15 one-pound bags of flour all day, every day, and then measure your muscle mass over 3 or 4 weeks. You will find it goes up. 15 kilograms, rather, of flour is a lot. And if people shed 15 kilograms of weight, The need for the major muscles, the paraspinal muscles, the thigh muscles, to cart around the body weight, that goes down. And people naturally come down a little bit in their muscle mass. That is not harmful. It is not loss of muscle mass that is damaging per se. So I would reassure you absolutely that yes, there is a small loss of muscle mass, but hey, you can propel the remains of your body far more effectively, and there's no concern about change of basal metabolic rate. That is part of the cloud of nonsense that's grown up around this subject. There are really so many myths in metabolism. I try and tiptoe around them because knocking too many myths tends to lose your friends. But we can be quite clear about the muscle question. This is not harmful.
Thank you, appreciate it.
Do you have any data in non-diabetic patients?
No, not personally, but I would point out that a similar sort of approach has been used in pre-diabetes by NHS England, and their intervention shows weight loss of, I think, 4.5 pounds and a really very substantial effect in preventing the progression to diabetes. So that's as far as I could go into non-diabetes. But I would just point out that there's more motivation for a person with type 2 diabetes to lose weight and get rid of the risk of complications than there is for a person with uncomplicated obesity who is just wanting to get rid of the obesity for all the reasons we know. So the motivation might differ, but sadly, no, I can't provide you any data.
Dr. Taylor, have any studies been initiated in obese children and their type 2 diabetes and obesity in children?
I can say yes in the planning. That's coming on. I've had numerous meetings with our pediatricians discussing just whether this could be applied, who it could be applied to. Now, in childhood diabetes, there are a huge range of problems. In Britain, if a child is substantially overweight, then it might be a pure genetic appetite syndrome. There might be terrible social problems, socioeconomic problems. And in the background, yes, we do have what you might call is ordinary obesity as well. For those children, yes, once they pass puberty, there will be no particular problem in using a low-calorie approach. We have nice data on growth velocities that was published a few years ago, demonstrating that this, in fact, is completely safe. Using a low-calorie approach for a short period of time is entirely safe. But I would emphasize that this is pediatric practice. We have to have the child on board, willing to do this, wanting to do this. But, hey, it can make such a huge difference to health because it's children with type 2 diabetes who are going to have the most vicious complications and the shortest, most unpleasant lives. So we've got a responsibility to try and offer this to as many as could feasibly undertake it. So I think this is an important area in terms of hard data. I hope we will be able to acquire that. It's not a study I'm running myself. I'm advising on this study, obviously being run by pediatricians.
Maintenance seems to be the crux of the long term, and I was just wondering, is the maintenance plan kind of specifically outlined in the book and you give all of the patients a book, or is there a way for you to maybe quickly summarize the key successes for maintenance for us?
The main points about maintenance are laid out in the book. They were largely, but not completely, followed in the direct study with the 5-year results I showed briefly. I'm currently in, we might say, animated debate with NHS England to try and get them to change this acute 1-year program into a program which has an ongoing follow-up period. But You mentioned the important factors. I would say, firstly, people have to realize that they remain at risk of type 2 diabetes, and there's a 100% chance the diabetes will come back if their weight returns to baseline. That's the first point that's vital to explain. Secondly, there's a matter of writing the weight down. Now, we could equally well use waist measurement, and that's perfectly valid if people find weighing themselves unpleasant for any particular reason. So writing it down every week, not more often than that, is really quite an important part of it. Thirdly, I would point out that if weight gain recurs, especially if it's during a life crisis of some kind, a financial problem, problems at work, family problems, problems with the neighbors, the cat's got leukemia, you name it. The number of problems that happen to people are it's very high. If the weight gain happens and the diabetes comes back, it's not a failure. It just requires time to pass until this person can get a hold of things again and then repeat the process. So getting that advanced rescue package into people's minds is important. And then finally, there's a matter about what people eat. Avoiding processed foods, fast foods, is obviously absolutely certain. Talking about portion size is also quite important. But beyond that, it's a matter of preference. Now, if people like and are willing to follow long-term the sort of diets that were being discussed in the lecture just before the break, that would be perfect and a good model to follow. But in general, a lower carbohydrate approach is important in the food environment that I see when I come to the States, is absolutely vital to try and avoid this excess sugar, which comes in and provides excess energy with no effect on satisfying appetite. So, in a nutshell, those are the recipes for maintaining remission. But I have to say, and repeat what you said, it's this long-term game that is the most challenging.
Thank you, Dr. Taylor. We are, unfortunately, we are out of time.
Can I ask one short one?
One short one? We can do one short one. How about that?
The rationale for the cutoff at 6 years for the duration of diabetes.
Okay, that is purely pragmatic for the reasons of conducting the direct study. It's the results from what we call the CounterBalance study, which looked at people of all duration. I can tell you that some people with very long duration type 2 diabetes can go into complete remission, but it's a relatively small percentage. Under 10 years, it's going to be 90% of people who lose 15 kilograms. So you can see that there's a sliding target for this. So the 6 year is artificial, and it's unfortunate that NHS England has adopted this, but hey, this is the power of health economics. You know, they've got to go with the evidence base, which came out of the evidence study, direct. And so that's where the 6 years comes from. It has a degree of artificiality to it, but it's useful to be able to say to patients in advance, look, you've had your diabetes for 12 years, there's a fair chance you may not get complete remission, but hey, you're going to be so much better off metabolically and health-wise if you manage to achieve the weight loss, whatever. If you get remission, fantastic. So that's how I would approach it.
Wow, thank you so much. This has really been an amazing talk to just solidify this evidence of lifestyle medicine back into our lives and our practices. Thank you so much, Dr. Taylor.
My pleasure.